We'll of course begin by acknowledging the traditional custodians of the land in which we meet today, and we'll pay respect to elders past, present and emerging. It's my pleasure today to be introducing Dr. Nikola Ognyenovits. Nikola is a medical officer who works within Metro North Alcohol and Drug Service. He also works with the Community Alcohol and Drug Service at Ipswich. But more recently he's been to a 3-day conference on psychedelic science in California. And that was in April, and he's retrieved some of the content from there and bringing it back to include in his presentation today, titled Psychedelic Science, Curse or Salvation.
Thank you, Rod. I also would like to acknowledge the spirits of this land and the keepers of this land, past, present and emerging. The title of the presentation sort of tries to raise the interest in the current state of how we view psychedelics in society. I would like to plagiarize one of the presenters at the conference, Dr. Gabor Mate, who started the way that 10 years ago, if someone told him if he was going to present on psychedelics, he would have asked them what drugs they were on. I'm a bit like the same. But in the last 10 years, brought in my life an interest in this area for very good reason. So where does psychedelic, the actual word, comes from? It is from ancient Greek, composed from psyche and delon, which is to make visible or reveal. So the meaning is soul or mind revealing or manifesting. And what I just read lately, that it was actually a creation of Aldous Huxley, who in his later years of his life was introduced to psilocybin, and it was a major part of his creative work in his writing. The synonyms and they are used for this word are hallucinogen, psychotomimetic, which means that mimics a psychotic state, and entheogen, which is the entheos, which is God or divine, again comes from Greek, and these substances generate a god's-like or divine state. In history, there is numerous information on the use and the respect for some of these substances. Ancient Greece, the sacred mushroom revered by the gods. South America, about 400 before Christ, these mushroom stones were created and interestingly destroyed by the Catholic monks later on. And a wall painting from the Aztecs, again where the god is touching the person who is the influence of a mushroom. So there's another area where it's still used pretty much in South America, in traditions, the ayahuasca tradition and the mescaline tradition in South, and which is the peyote cactus use. Now, modern psychedelic science starts with this scientist. His name is Albert Hofmann, and he synthesized LSD in 1938 with the intention of creating a respiratory and circulatory stimulant for a company he was working for, Sandoz, which is now a subsidiary of Novartis in Switzerland. He then re-synthesized this drug in 1943 and accidentally somehow touched the substance, maybe wiped his mouth or got into his eye. But what happened is, when he went home very soon, he experienced some very substantial effects, which I read out. Affected by a remarkable restlessness combined with slight dizziness. At home, I lay down and sank into a not unpleasant intoxicated-like condition characterized by an extremely stimulated imagination. In a dreamlike state with eyes closed, I found the daylight to be unpleasantly glaring. I perceived an uninterrupted stream of fantastic pictures, extraordinary shapes with intense kaleidoscopic plays of colors. After some 2 hours, this condition faded away. Now, it's interesting to see that Hoffman remained active at the tender age of 102 years old. And he was still conducting research, and he was still giving lectures, which he was actually booked to do in 2008, but he couldn't make it because of ill health, in which year he died. Close co-workers confirmed that he was microdosing LSD for at least the last 2 decades of his life. A recent article from the Rolling Stone magazine, which I'm not sure how much you are aware of, but it is becoming a trend of some, especially California, Silicon Valley scientists who are microdosing and find LSD and find that it really helps their creativity at work. Microdosing means that you take the amount of LSD which does not cause any of the psychedelic effects. So a psychedelic dose of LSD is around the 200-300 microgram mark, and microdosing is 10 to 20 microgram every 4 days. That's about the recommendation. With microdosing, there's interesting that it's also known that in Brisbane some psychiatrists are microdosing ketamine to a lot of the patients. So again, it's a subset that are using for some creative work and relieve depression. Between 1953 and 73, there were over 116 studies in researching LSD. So that was 20 years. So if that drug was that bad in research, they would have stopped it, I think, a bit earlier. But what happened that in 1970, and it started from the late 60s, that states started to prohibit the use of LSD and psychedelics because of the emerging use in the counterculture. And they scheduled it Schedule 1 drug, which means it had no place in anywhere use, and it's actually a dangerous drug. So it's highly addictive and it's dangerous, and there's no place of any medical research. So the research projects were shut down, but lately quite reputable universities, Johns Hopkins, New York, California, New Mexico, University of Zurich, Imperial College, and others started embracing research again. And so far they've been some preliminary results of these substances being useful in nicotine addiction, alcoholism, depression, and end-of-life anxiety, PTSD treatment. Most of these studies are actually not funded by the institutions or the states. There are some organizations which do the fundraising, and these 3 are the major ones: MAPS, the Beckley Foundation, and Hefter Research Institute. James Fadiman is an old researcher, says a pharma company needs to figure out how to make an obscene profit. That's what gets their attention. The problem is that these drugs are not addicting, and you don't need to take them very often, as we will see further in the presentation. Now, the categorizing of psychedelic drugs, the classic psychedelics are the serotoninergic psychedelics, the tryptamines, which all work on the 5-HT2A receptor, LSD, psilocybin, DMT, and Ibogaine. Ibogaine is a complex tryptamine which also works on the MDMA receptors and the kappa opioid receptor. So it results in dissociative effects as well. The other big group is the empathogen or entactogen, the phenethylamines, which also work on the serotonin 5-HT2A receptor, but they also cause serotonin reuptake inhibition. And these are MDMA, MDA, mescaline, mephedrone, 2-CB. And then the dissociative NMDA antagonist, which is the major one, is ketamine. As I mentioned, Ibogaine has a partial effect. And the atypical, which is the active ingredient in Salvia divinorum, salvinorin, which is a kappa opioid receptor agonist. With phenethylamines, tryptamines, and the LSD, you can see that they all have a major effect on the 5-HT2A receptor, which can be blocked by a substance called ketenserin. So if you give ketenserin, it actually blocks the effects of any of these. What the other interesting thing about this slide is that LSD is also called the promiscuous tryptamine, because it works on many other receptors like the dopamine receptors and alpha receptor as well. Now, what's also interesting to see is the chemical structure of these substances and how they are similar to just our endogenous neurotransmitters like serotonin and dopamine. So if you look at the substances, they all have this indole structure, right down to LSD, psilocybin. So, and the other thing is, I attended the conference, which was a 3-day conference, but I also attended 3 workshops, one on psilocybin, one on psychedelic neuroscience, and a third one on ketamine. They were 1-day workshops. And the neuroscience workshop, it was one of the highlights where they explained how receptors work. And the receptors, actually, like the serotonin receptor, is not like a static receptor. It's not like that any substance that goes there will cause the same effect. So what they call as a functional bias. So if you put on the same receptor, you put LSD, you will have a very different response through that same receptor. I'm not sure whether you guys are interested in it. I find it fascinating. The other issue is that we're probably not aware of that these substances, because they're very similar, the development of LSD helped modern psychiatry in a way that when LSD was first researched and given, it caused this transitional psychotic-like state, and then later on, a few years later, they actually synthesized serotonin. So they put 2 together and found that psychosis has got a lot to do with neurotransmitters, which before, if you had a psychotic illness in the 30s, for instance, your parents were blamed for that, not your biochemistry. So that helped transitioning into the neurotransmitter concept of psychiatry. Ketamine, again, it's got a similar ring, and salvinorin, which is interestingly quite similar to morphine, and it works on the kappa opioid receptor. I'm not sure how many people attended the APSAT conference in Brisbane 3 years ago. Well, we had a keynote speaker called David Nutt. David Nutt was a chief advisor of the British government until he got literally sacked because of his views not fitting the political agenda, saying things like that MDMA is less harmful than horse riding, and he proved it scientifically. And also what he always says, that our major substance that causes most of the harm is alcohol. And everyone in the scientific field agrees to that. So if you compare alcohol, harm to others and harm to users, with LSD or mushrooms, that's minuscule. So it was obviously a political decision to withdraw these substances from the scientific field. Now, this study was actually replicated by the European Union Psychiatry and Drug Committee, and they found a very, very similar result just lately. Now, about the conference. It was in Oakland, California, in a large, or probably the largest conference center, in the Marriott Conference Center in Oakland. Is just across the bay from San Francisco, so it's like just a short train ride. There were over 3,000 attendees. They expected about half. Last time, 4 years ago, it was about 1,300. And most of these people that you saw there, when you go to a conference like this, you think you're going to see all these old hippies. There were probably a dozen of them. And most of the people who attended and I spoke to, they were either researchers, PhD students, or postdoctoral fellows. Very far from the old TPC. It's just a picture of the Golden Gate at night. Another concept that I would like to introduce, I think it's very important in the understanding of how psychedelics work, and I only just learned about this at the conference, is the default mode network of the brain. There are regions in the brain that are located in the prefrontal cortex and the lateral inferior parietal cortex and the posterior cingulate cortex, which are deemed to represent an area which is supposed to be the anatomical basis of the sense of self, the identity of who we are, and the capacity for introspection. This is the area which undergone very significant evolutionary expansion and also an ontogenetic development compared to a small child's default mode network and adult. This area grows disproportionately more than other areas of the brain. It serves as an important convergence zone. Some people liken it to it is like the capital of the brain, where everything comes, all information comes and gets sorted out. It also activated in high-level thinking, as like predicting the future, making personal, social, moral judgments, contemplating the past. So there is some assumption that this is the basis of the psychological sense of self or ego. This is also a resting network. So when we are not doing any particular task, this network is always active and fires. What's also interesting, in depression and anxiety states, this network overfires, it's overactive. The other network which works in limbo with this network is the task positive network, which sits in the dorsolateral parietal cortex and the anterior cingulate and posterior parietal cortex. It is active when we attend to things in the external world, we attend to other things other than ourselves. It is in gear when we have our attention externally focused and up in something, getting something done and forget about ourselves in the process. This is the anatomical diagram where these two networks sit in the brain. So compare the two networks. The two modes of consciousness do not in ordinary waking consciousness become activated simultaneously. So it's either one or the other. They exist side by side and they have a competitive relationship. Each become active when the need arises, and they alternate with very extraordinary rapidity. Can switch from one to the other very quickly. And they provide an alternative way that we view human consciousness compared to the left and right brain theory, which has been prevalent for many years. Now, a functional MRI of the default mode network and a study. So, comparing placebo with psilocybin, the effects on the brain. So what we see here, the default mode network, which is the anterior cingulate and the posterior cortex, became inactive under psilocybin, and there are other connections arising. So effects of psilocybin on the two networks significantly decrease the activity of the default mode network, and the actual competition breaks down between the two networks. So they actually work together. They get connected. A study where they looked at brains of people who used ayahuasca long term, and they found that ayahuasca users had a thinning of the posterior cingulate, which is the major site of the default node network. And these studies have been repeated people who were like long-term meditators. So anything that can reduce the activity of the default mode network can bring us more into the presence, can reduce anxiety and depression, according to this theory. As another interesting study, ayahuasca stimulates the birth of new brain cells in an in vitro study, which was done at the Research Institute in Spain. So harmine and tetrahydroharmine, they are some of the active ingredients in ayahuasca. And if you treat this neurocell culture just with saline, you will see the cell centers. If you treat it with harmine, you will see growth of new neurons, which is the green in this slide. And if you give tetrahydroharmine, which is another one, it will then result in even more vigorous growth in that culture. So maturation of neurons. The Beckley Foundation is a major source of funding science in psychedelic research. They actually raised about $80 million so far, and sponsoring many projects around the world. Their directors is Amanda Fielding and David Nutt, that I already mentioned. There is a study that comes out from their hub, psilocybin with psychological support treatment-resistant depression. About the study, they presume that it will help the depression in people who at least tried 2 different treatments and were resistant. And the length of depression was at least 18 years, and the participants received 2 doses 7 days apart, and compared and accompanied psychological support before, during and after each session. All participants showed improvement, and 67% scored at levels which was consistent with remission, which if you compare it with antidepressants, that's a very significant result. And obviously the study wasn't very powerful, and you have to look at selecting patients and everything else. But if you just see that there were 12 patients with treatment-resistant depression, I think it is already significant. Depression severity, if you compare it with the start, the baseline, there's a significant difference, 50% at 3 months. The same again here. Compare with other medication and therapy. So these patients only got the supportive therapy, but not the substance, and the difference is remarkable. One of their very broad research to show how LSD actually works in the brain with neuroimaging, and they found that there is significant connectivity on their LSD between brain areas which are normally not present. Again, David Nutt was interviewed in the Insight magazine earlier this year. He was asked, so we are talking about people suffering from anxiety and depression. The default mode network is generally overactive in people with those disorders, and psilocybin has been shown to turn off the default mode network and allow the brain to behave in ways never seen before. But we still know very little for certain. Isn't that terrifying? And David Nutt answered, the point is we don't know about it because no one has done it before. It's quite fascinating. Getting some of this stuff published has been quite difficult. A lot of scientists would prefer if this whole thing went away. It raises challenges to philosophies and theories of science. It is like Einstein. we had a naive theory of physics, and then suddenly relativity comes along and we have a different theory. Similarly, we had a naive theory of consciousness, but then our work comes along and says actually there is another kind of psychedelic consciousness, and that's associated with very different brain activity. Another organization is called MAPS, Multidisciplinary Association Psychedelic Studies in the US. They actually the ones who organized the conference in California, and their primary research is MDMA-assisted psychotherapy in PTSD. I think it deserves a little bit of detailing. One of the stage 2 studies that came out in 2010. This is the design of the study. So, I mean, a lot of people take MDMA and a lot of people use psychedelics, and they don't get rid of their depression. And some of them actually have a terrible experience, and things get worse for them. So what's the difference between using MDMA in this context or other psychedelics and the common use? From this study design, we actually see quite a lot of the difference. These patients were screened quite thoroughly. People who had any psychotic diseases, they were excluded with active psychosis. People who physically were not capable of undergoing this treatment, they were excluded. So there was a very rigorous patient selection. Also, it doesn't really come out. It comes out. After the selection, there were 3 preparatory sessions, each of them 90 minutes, which is to familiarize with the therapists. There's always 2 therapists, a female and a male. So by the time the experimental session comes along, they will be familiar with the therapist, be comfortable with them, be in a relaxed environment. So then comes the experimental session with MDMA, after which you've got 3 90-minute integrative sessions again with the therapist. And a few weeks later, repeat the whole thing again. And people who had placebo had an opportunity to experience MDMA later on and have the same protocol repeated there. So these were the results. They're the 2 markers of PTSD, and that's the placebo line and that's the MDMA line. So which means everybody went through the same psychological support, the psychotherapy, but the placebo line did not get MDMA, and there were significant differences in the result. And the therapist would never know that they had it or not. I mean, obviously you can say that you will recognize if someone had MDMA or not in a therapeutic session, but that's just something that we have to accept. This is one of the settings, how it happens. So the 2 therapists and the patient in a comfortable position. There is always music going, and the same set of music. It's normally some soothing music that does not connect. It's not like rock or anything that's too strongly would alter the ways of your therapeutic session. Just a few attributes how the therapeutic alliance, how the therapist should participate in this session. And what we know is that they have to be very non-directive. They just have a supportive role. They should really get rid of their own agenda. I love this slide. Please consider this before talking. So whatever you hear from a patient always gets through your own filter. And you do not interpret it. You just support the patient to go with it and work in their own context. Another setting in another study place. So it's what's important, that it's not a sterile hospital environment, which will also alleviate anxiety related to that. And a follow-up study of the durability of the effects. So 19 subjects who received MDMA treatment, 16 completed the outcome measures, and this was administered 17 to 74 months after the original study. And it was found that subjects maintained statistically and clinically significant gains in symptoms relief, except for 2 who relapsed. So 2 relapsed out of 16 who completed the outcome measures. Showing there were some other sites of the study which found pretty large effects again, except for this one had a small effect, possibly because they compared reasonably high doses between the control. Another hub of research is the Hefter Institute, based in the US, again associated with the major US universities that I mentioned at the beginning. So their main and most probably published research was associated with psilocybin in anxiety and depression in life-threatening cancer patients. This study is very well known. Again, no large numbers, but very rigorous study. Again, a very similar pattern how the PTSD study was conducted. 3 sessions before session, 3 integrative sessions again, and the second session. Now, in this study, they used niacin for placebo, and they crossed over between the 2 sessions. And these are the results. So, significant improvement in depression and anxiety scales. One of the principal researchers, Stephen Ross, who is a professor in psychiatry in New York University and also director of substance abuse division in Bellevue, wrote this: "I thought the first 10 or 20 people were plants. They must be faking it." So think about this is a regular psychiatrist trained in very traditional ways, getting involved in this psilocybin study. So they were saying things like, "I understand love is the most powerful force in the planet," or "I had an encounter with my cancer, this black cloud of smoke." People who had been palpably scared of death, they lost their fear. The fact that a drug given once can have such an effect for so long is an unprecedented finding. We have never had anything like that in the psychiatric field. There was another study conducted in very similar ways, but they actually used placebo, and they have very similar results. They didn't have an active placebo. Again, anxiety scores. So 6 months after, anxiety scores are reasonably or very significantly lower. As a little study of psilocybin facilitated smoking cessation, where they found that 15 subjects at the 12 months follow-up, 10 participants, 67% were smoking abstinent, and 9 participants were confirmed. The 12 months follow-up, 13 participants rated their psilocybin experiences among the 5 most personally meaningful and spiritually significant experiences in their life. Another study in alcohol dependence, proof of concept study, again just a small one, 10 volunteers, and abstinence did not increase significantly in the first 4 weeks of treatment, which was psychotherapy, and increased significantly following administration of psilocybin, and maintained at follow-up at 36 weeks. I would like to talk a little bit about Ibogaine. I'm pretty sure that most of you heard about Ibogaine and had some patients who might have asked you about Ibogaine, because it's in the underground treatment. as I mentioned before, Ibogaine is similar to some of the psychedelics, but also different in some effects. It is a very powerful agent. It has some effects of QT prolongation. It also causes very significant purging, which is vomiting and diarrhea. So can cause electrolyte imbalances if someone's already had them and not prepared. And also it has a significant effect on opioid signaling. So people who take Ibogaine, most of people who take Ibogaine, they take it because they want to get rid of their opioid dependence, or want to avoid withdrawal symptoms. If you're still under the effect of an opioid, Ibogaine can kill you because it will potentiate that, even that little bit of effect of opioid that you have in you. So most deaths that were associated with Ibogaine, they were people who got it from the internet and did it themselves without any proper preparation and any support. Now, there were deaths associated in controlled settings, but we all know that those controlled settings were not controlled enough, and they were not properly monitored and screened. So this study again was done in America in these departments and published in the New York Academy of Sciences Annals. And it proves that the desire to use Ibogaine, intention to use opioids pre and post Ibogaine significantly reduced. I'm sorry, I'm a bit fascinated by David Nutt. I love his work, and I just would like to finish with this quote. This is the worst censorship of science in the history of the world since the Dark Ages. It's worse than the Catholic Church banning the telescope in 1616. David Nutt. Thank you very much for your attention. Any questions?
Did you note any side effects from the drug?
Which one?
Psilocybin.
Very, very little side effects, and nothing that cannot be controlled. Again, these people are all monitored. As you notice, they actually have a monitor there. And in the MDMA study, there was one that had to be withdrawn, but that particular person had a psychotic relapse, not physical.
If the psilocybin, I think it was called, causes an increase in the brain activity, would there be a possibility of harms associated with long-term use, as in the brain kind of burning out after being kind of in this hyper-alert state in the long term?
Well, this hyper-alert state is transitional. So there is no evidence that people who use mushrooms on a more controlled basis, they will have long-term effects from psilocybin. Absolutely no evidence. So this increased connectivity is not like hyperfiring. So it's not like an overfiring of the brain. It's just connectivity that normally is not happening.
Sorry, we have a question from the web. Someone's wondering what might be the barriers to conducting psychedelic therapy in Australia?
Approval of the studies. I know there were applications put in to be part of the MDMA study from MAPS, and that was rejected. I think there is still a lot of resistance. Well, as I said, if you asked me 10 years ago, I would have been very suspicious of the whole thing. But since then, I familiarized myself through various impulses in my life and found that it is a fascinating field, and it's got a lot to offer which we are missing out on. I think, as I mentioned before, banning these substances was purely a political decision. There was at the time no evidence other than the counterculture threatening the very basics of Western society, banning these substances. So what else I probably want to mention, that within the psychedelic world there are some conflict. People who think the old way compared to the new scientific approach, that the psychedelics will never properly lend themselves for current scientific approach, which I think has proven that it's not true. There is a camp which is more advocating the traditional substances like the ayahuasca, the full cannabis instead of the synthesized cannabidiol or THC division. So it's the laboratory psychedelics against the traditional shamanic substances, and they both have their merits. For instance, what was also mentioned, that if you use mushroom, which has got the active ingredient as psilocybin, it will come with many other alkaloids, and in most people it will actually induce purging. So you will have vomiting and some diarrhea. If you just give pure psilocybin, that's very rare. So, but some people say that those alkaloids actually have positive physical health effects. It's a cleansing. So there is always pros and cons between the two.
I had a client who went off his opiate program and went down and used Ibogaine at Salford down on the Gold Coast, and that was unsuccessful. He relapsed and came back on the program.
Yes. I mean, the underground Ibogaine movement again is definitely not that thorough, what I showed in the studies. So I know the Ibogaine provider at the Gold Coast. I know he's very supportive, and I know that he won't give that sort of psychological support. So the way we actually view the work of these substances is that it potentiates, it allows the subject to deal with those emerging psychological issues in a very safe, protective environment, supporting the subject with working on those issues and progress with them and put them in a different context in their life. So if that's not thorough enough, then the substance by itself will not work. It gives you an opportunity, it opens doors, but what you do then when you've got that open door, it really depends on what you find on the other side. So yes, I mean, in some people, one Ibogaine treatment in a good setting can help. I know that particular provider at the Gold Coast had one Ibogaine, and he actually treatment in Amsterdam, and he after that never used opioids. And that's why he started himself, because it worked on him very well. But it's not the magic bullet. If you don't change your life, if you go back to this original setting that you had before, and there's no support from family, friends, environment, Ibogaine itself will not prevent you from relapse. It gives you a chance, but not a definite treatment. It's just a modality. I'm not saying that this is going to be the answer for everything. It's just something that I think it's got its merits, and it has a potential of using it in our armory in treating substances and in treating psychological issues and sometimes psychiatric treatment as well.
Well, thank you very much, Nicola. It's certainly lots of food for thought. I think you've got us really thinking about that now, so we appreciate that. And if you join me in thanking Nicola for his presentation today.